How many of you here are electrophysiologists? Very few. All right. So hopefully this presentation will really help us understand a little more about the electrophysiologic aspects of the appendage, in addition to all the structural things that you guys have wonderfully shown to us today. So these are my disclosures. So when we look at the left atrial appendage, the embryological aspects of it, I think, are worthwhile reviewing. If you really look at the evolution of the human heart, the development starts about 4 weeks, and then it evolves. Most of the left atrial appendage that we see here is basically the primordial left atrium that evolves and pushes itself towards one side of the heart, and the rest of the atrium is basically represented by the pulmonary venous buds and the sinoatrial bud. So is there a correlation between the thrombogenicity, arrhythmogenicity, and what all else that this ubiquitous cardiac vestige creates? And is there a correlation between the embryological origin of this? That's a question that I think we really need to ask and really probe further, and I don't think we really have any answers of that. So from a functional aspect, if you really look at the left atrial appendage, and then ask a question, what is it that we're going to do to it if you ligate it or if you occlude it? I think if you created an electrical exclusion, which is possible by doing an epicardial ligation using a LAA device or an AtriClip or something else, you can affect the neurohormonal regulation, or you can probably affect the appendage as a source of cardiac arrhythmias. And then from a mechanical aspects of it, you could potentially reduce the clot formation and systemic thromboembolism, and then the so-called cardiac reservoir function. So since my talk is limited to cardiac arrhythmias, this is what exactly we're going to talk about. So why is appendage arrhythmogenic? If you really look at the histopathological aspects of the appendage, it's mostly trabeculated and has extensive pectinate muscles, and there is a significant amount of diversity in the orientation of the muscle fibers beyond the ostium of the appendage, which in turn could result in some electrophysiologic changes, resulting in differences in wave propagation, conduction velocities, and thereby becoming a potential site for reentry or trigger mechanism. So this is a classic example of a nice case of atrial tachycardia where somebody had an incessant ATAC seen by an electrophysiologist. They took him to the lab. They did a nice three-dimensional electron-atomic mapping looking at the activation of this atrial tachycardia that obviously seems to be coming from the tip of the left atrial appendage. Even after extensive ablation, they were unable to get rid of the arrhythmia, and that finally led to a surgical approach where they placed an external device to clip off the appendage, where on the bottom portion of this screen you would see right around there, you see the tachycardia terminate as the blood supply to the appendage is gone and the patient is back in normal sinus rhythm. The follow-up CT scan clearly shows that the appendage is ligated and gone. So that opens up the discussion to several other types of arrhythmias that we see. So there are several series of atrial tachycardias that have been reported that seem to originate from the left atrial appendage, some that come from distal portions, some that come from proximal portions, and some that come from the right atrial appendage, and so on and so forth. So even in patients who have more of a persistent atrial fibrillation, this is a nice paper from the Bordeaux group that clearly described that the left atrial appendage is a seat for atrial tachycardias in about 20% of the patients. Focal micro-reentry seems to be a mechanism in this, and almost all of these ATs were localized to the base along the pectinate ridge in this particular case. So this is, again, a very nice map that clearly shows the centrifugal activation of an atrial tachycardia focus, and in some cases, they were mostly reentrant tachycardias. Sometimes these appendageal tachycardias or appendageal arrhythmias could be epicardial in nature, and access to these arrhythmias from inside the appendage could be very tricky. And as a result of which, ablation of this can also become extremely difficult. So there are several papers that have been published over the last few years clearly highlighting the role of the left atrial appendage in arrhythmogenicity, both as focal standalone atrial tachycardias as well as in combination with atrial fibrillation, where it can become a potentially bigger trigger for atrial fibrillation initiation and maintenance. So this nice paper that was published in 2010 by Andre and Natale's group actually highlights the role of left atrial appendage in arrhythmia initiation. out of 987 patients, they had about 27% of the patients who actually had focal triggers from the left atrial appendage. And 9% of these patients actually, appendage was the only source. It was not the pulmonary veins, but appendage was the only source. So again, these are electrograms that clearly show the focal triggered effect that originates in the left atrial appendage. And this is what happens when you isolate the appendage. And oftentimes, isolating the appendage from inside is really not an easy job, and it requires a significant amount of technical expertise, and there are a lot of technical issues as well as procedural complications that could come from that. So once you get the appendage isolation, this is what happens to people. Their long-term freedom from atrial fibrillation is significantly better. So instead of focal isolation, focal ablation, if you really perform the entire appendageal isolation, your outcome seems to be dramatically better and different than those people who actually do not have any kind of appendageal ablation. So what are the potential flip sides to the appendageal ablation from inside? As we are aware, this is really not a rounded structure, so because of the edges and the ridges and the differences in orientation of these edges, oftentimes having a catheter that is stable around the appendage is next to impossible. And the risk of perforation in these thin pits that are around the left atrial appendage, as Dr. Ho has shown this morning, some of these pits are actually less than 1 millimeter in thickness. So you can imagine a catheter getting caught in these pits, and once you burn, you know the obvious what's going to happen next. And what happens to the left atrial appendageal atrial contractility, and what is its effect on emptying velocities and stroke volumes, and the future implications to thrombus formation and systemic anticoagulation are all bigger challenges that we really need more answers for. So with that being said, there is very good data that is clearly shown from the AtriClip studies that if you deploy an AtriClip, you can actually get a very good entrance as well as exit block, which clearly is what we really know that pulmonary vein isolation really does, and this is exactly what you know for appendageal exclusions. So left atrial appendage is structurally the most non-homogeneous structure in the heart, and it is the second most common source of focal triggers and regional reentry after the PVs. And oftentimes, it is only electrically active structure in patients with significant atrial myopathy. I think for those of the EPs around here, it's not unusual when you really see an elderly female patient that's around 70 years who often has sinus node dysfunction, and they have a very rapidly progressing paroxysmal atrial fibrillation, failing multiple antiarrhythmic drugs in a very short period of time, where you get excited about maybe atrial fibrillation ablation is the solution there, and you take them to the lab, you map it. The entire right atrium, left atrium is completely scarred out, and the only structure that's alive is literally left atrial appendage, and any amount of arrhythmia that you see focally comes from this left atrial appendage. And maybe these are the patients that we should be targeting specifically for a left atrial appendage ligation or elimination. So all in all, when you eliminate the left atrial appendage from the electrical milieu, it would probably reduce the arrhythmogenicity. I think it's just application of common sense. So when you apply the same concept to some of the devices that have been around, which is an epicardial ligating device, which is the Lariat device, this is an example of what happens to the appendage. It's very similar to what happens to an umbilical cord. You tie off the appendage or the umbilical cord, over a period of time, it's going to atrophy, shrink, and disappear. As a result of which, whatever electrical activity that comes from this structure is automatically gone. This is a nice example of a patient who had a cardiac transplant after a ligation of the left atrial appendage using the Lariat. You can clearly see the dense fibrinous scar formation and the atrophy of the appendageal structures, clearly highlighting that there could be some electrical changes that would be happening here. So when you tie off the appendage epicardially, you are essentially getting rid of the blood circulation to this, as a result of which there is ischemic necrosis of the structure. So that results in a dramatic drop in voltages, and over a period of time, it becomes electrically silent. So extending that concept, we went back and looked at all our patients who had Lariat devices, patients who had cardiac implantable electronic devices, which includes the pacemakers, ICDs, and CRTDs. And we looked at their arrhythmia burden. This is pooled data from multiple institutions. And this is what happens in these people. On the first example in figure A, you would see that somebody who was in persistent atrial fibrillation immediately after the ligation of the appendage, the AFib terminates. And then subsequently, you can look at the dramatic drop in the AFib burden in those people. And similarly, you have another patient who has paroxysmal atrial fibrillation of a very high burden, and then once you ligate the appendage, there is a dramatic effect. This may not be something that you see in everybody, but there are more than a few patients that when you ligate off the appendage, you do get a significant drop in the AFib burden. So we have noticed about a drop from 81 to 42% acutely at 3 months, and then at about 12 months, this number still persists to be reasonably good, about 65%. So extending this concept to a more organized effort, which we call as the LAA AF Registry, where we performed sequential ligation of the appendage using an epicardial device followed by AFib ablation in patients who have persistent atrial fibrillation. So out of the 62 patients that have completed a one-year follow-up, we actually saw a significant reduction in the AFib burden, which we will come to in the next few slides. What you got to pay attention to here is look at this particular appendage. So the CT scan of the left atrium to the left is before the ligation. The one to the right is after the ligation. And if you look at the volume numbers, there is about a 30 cc drop in the volume of the left atrium. That means there is 30 cc less left atrium that is available for the perpetuation and the maintenance of atrial fibrillation. Perhaps this significant volume reduction could be a potential mechanism where the arrhythmia persistence is probably a lot lower than what we think it would be. And if you look at the three-dimensional electroanatomic mapping, this is a NAVIX map of the left atrium of the same patient, where you see a very nice smooth mound in the place of the left atrial appendage, which is completely scarred out. And we did a pulmonary vein isolation in this patient. And you also see that the posterior wall is already scarred out. And we challenged this patient with a very high dose of isoprel, and there were no triggers, and there were no reentrant circuits that we could induce with burst spacing and programmed electrical stimulation. And that essentially led us to a final cavertrax brismus ablation, and the patient did phenomenally well. So if you looked at their outcomes at 12 months, the recurrence rates of arrhythmia is significantly higher in those patients who actually had AFib ablation alone. It's at about 47% compared to 32%. Obviously, more repeat ablations were needed in the group that did not have the appendage isolation done. And in fact, we actually saw some stroke benefit as well. So there were 2 TIAs in the group that actually had the AFib ablation alone for the most obvious reasons. So the subgroup of patients who had a leak of about 3 millimeters median actually had a much higher recurrence, clearly highlighting the fact that when you do not accomplish electrical isolation, it is difficult to actually get a complete rhythm control in these patients, and the contribution from the appendage still continues. So this is a graphic representation of the same results as we talked earlier. So let's extend this concept to what happens to the mechanical occluding devices. Do you really get a very similar effect? Is there a difference between ligation of the appendage versus an occlusion of the appendage using an occluded device? So we looked at all the patients who had a previously placed Watchman device that have come to our institutions for AFib ablations. And this is a nice example of a Watchman device sitting in there, and the 3D cartomap, a shell, and the obvious pulmonary vein isolation, and the linear lines were delivered in this particular case. So we looked at about 48 patients from multiple institutions. Obviously, all of these patients had a relatively higher CHAT score, a relatively bigger atrium. And interesting enough, 23% of these patients actually had less than 5 millimeter peri-device leak, and this continued even at the time of ablation. So 36% of the patients actually had antral isolation, technique differences, and about 64% underwent wide antral circumferential ablation. And about 23% of these people actually had some form of cafe or linear lesions, depending on what the operator thought was best for them. The left atrial appendage was active in about 30 people. That is 64% of the people still had an appendage that was electrically active. And this seems to be significantly more to be in patients who had a leak than those without a leak. And there were about triggers in 12 patients, and complete isolation was possible by burning around the Watchman in 5, and we could not isolate it completely in 7 patients. So almost every patient we were able to ablate around the posterior margin, but the anterior margin was difficult in some cases. And the outcomes were reasonable at about 71% because this is a mixed bag of paroxysmal as well as persistent cases. So if we go back and ask the question, how does the left atrial electrical exclusion really help the atrial arrhythmias? I think we can summarize that into three categories. I think it helps us to eliminate the triggers, it helps us to eliminate the reentry, and it helps us to reduce the atrial volume and substrate reduction for AF perpetuation. And I think there is a significant component of the impact of appendage elimination on the renin-angiotensin activation system, which is a separate study that we looked at called the LAA homeostasis study, where there seems to be a dramatic reduction in the levels of epinephrine, norepinephrine, aldosterone, and renin. That seems to be a bigger player in that. And what is the effect of the ligation on the cardiac gangliated plexi? So does the mechanical occludus have a similar effect like an epicardial ligator on the left atrial tissue viability? With the case of the occludus, it is probably reasonable to say that the tissue in the left atrial appendage may not be completely dead. We may have certain amount of peri-device fibrosis where the anchors get in, but we don't really know what percentage of these people really get a transmural scarring to really translate into arrhythmia burden reduction and so forth. It clearly opens up discussions onto what is the impact of these devices, both endocardial devices and epicardial exclusion devices, on improving the overall rhythm control as a conjunctive strategy to AFib ablation, which needs to be studied in a more randomized control fashion. And how does this really impact the long-term risk of stroke in these patients if you use this as a conjunctive therapy in addition to their AFib ablation? So with that, I stop here and thank my appendage team. And I think the creative power of thinking can really take us a long ways. Thank you very much.
Thanks a lot, DJ. We have time for one or two questions right now. One point is you said there is volume reduction of the left atrial volume, but isn't it even more because the surface, because due to the trabeculation, the surface is even larger in relation to volume. So maybe excluding the left atrial appendage takes away much more surface, electrical active surface than even volume. Is that, I think that's...
Very, very true. I think if you really equate out and equate the volume to surface area, the reductions in surface area are probably a lot more than the volume in itself. And clearly, the amount of atrial tissue that is available for perpetuation of the fibrillatory waves would be a lot less when you really exclude the appendage electrically from the rest of the atrium.
Do we have any good data about AF burden in paroxysmal atrial defibrillators who receive devices on a long-term basis? Do we see positive effects?
Some of those, out of those 44 plus patients we looked at on the cardiac devices, some of them had paroxysmal AFib, but a wide majority of them actually had a relatively higher AFib burden. So even though they were paroxysmal, you had patients with a burden of about 50, 60%. So in those cases, we did see some reductions, but again, appendage ligation by itself is not going to eliminate AFib completely. I think it's going to be an additional factor in addition to the pulmonary veins.
So thanks a lot.
Just last question, maybe. What's the when you do an ablation for AFib? It's a question from an interventional cardiologist. How often do you ablate around the osum of the appendage?
In persistent cases, or even in paroxysmal cases, when you challenge them with large doses of isuprel, and if you have a focal trigger that does come from the appendage, then those are the times we would like to eliminate that particular trigger. And I would say in our practice, which is sort of skewed because of the referral base, we probably do that in about 25–30% cases.
Interesting. And what's the risk to create a micro reentry by putting a device in an appendage?
Can these occluded devices create a micro reentry? We have not seen that, but I think the micro reentry could be related to the appendage in itself, the way the muscle fibers are arranged.
All right, thank you.